The technique presented in this video is called anatomic vaporization of the prostate. It's realized with the Green Light XPS laser 180 watt. It is an effective technique, standardized and reproducible, gets high patient satisfaction with little or no risk. Before starting the procedure, it is essential to identify the markers of safety on the fiber. They must always be under vision during the action of the laser in order to avoid damage of the distal end of the telescope. The small bubbles escaping from the distal end of the fiber are proof that the internal cooling system is working properly. Once the laser is activated using the black pedal on the foot switch, the fiber projects a red color pointer on the tissue to be used as a guide to direct the beam. The vaporization is started by pressing the yellow pedal. To achieve a proper vaporization technique, rotate the fiber slowly and with a rotation angle not exceeding 30 degrees. This allows an effective and progressive vaporization. The fiber must be at a distance of approximately 0.5 of a centimeter and fire perpendicular to the tissue. The working distance must be adapted to achieve the production of large bubbles, a sign of efficient vaporization. After checking the location, function and shape of the striated urinary sphincter, proceed with a detailed visualization of the prostate with a focus on the VERU MONTANUM. Subsequently, perform a careful cystoscopy with an accurate view of the ureteral orifices. Start the intervention with the creation of an anterior channel to improve the flow for bubbles between 11 and 1 o'clock. This step is very useful, especially if the prostate is particularly occluded. Pay close attention to the apex, which must be carefully deobstructed. The surgeon should always have a clear understanding of the position of both the VERU MONTANUM, distal anatomical landmark, and the sphincter. These landmarks are essential for guidance throughout the procedure. The production of large bubbles during the process of vaporization is a symptom of an efficient job. In order to create a large cavity, but especially to prepare the treatment of the posterior lobe, vaporize regularly lateral lobes from proximal to distal, and preferably with symmetrical action, first one side and then the other. During this phase of the intervention, always remember the rules of a good vaporization: minimum rotation angle, appropriate distance and perpendicularity from the tissue, and the production of large bubbles. The objective of this phase is not the achievement of the capsular plane, but to create a central cavity that is wide and regular. After achieving a wide opening, create two channels, large and regular, starting from the bladder neck, both at 7 and 5 o'clock, down to the sides of the VERU MONTANUM. Perform carefully this phase of the procedure. Focus on the paracollicular tissue and, making use of the distal end of the resectoscope, seek for the capsular plane with a delicate dissection stroke with the cystoscope tip. Perform this disconnect, first one side and then the other of the VERU MONTANUM. Then join the plane vaporizing the crista ureteralis. The control of bleeding on the capsule is achieved thanks to the function of coagulation activated via the blue pedal on the foot switch. Gently lift the adenoma, dividing it from the capsule through a mechanical action from left to right and vice versa. Insert the fiber into the gap between the capsule and the adenoma. Turn it up and vaporize the adenoma with the back face of the fiber to the capsule. This way, the surgical capsule will be preserved from irradiation of the laser. Advance gradually, raising the adenoma from VERU MONTANUM towards the bladder neck, alternating dissection with action of vaporization and coagulation. Remove the tissue alternately from above or below as necessary. Perfect lateral lobes vaporization following the depth of the surgical capsule visible on the posterior lobe. Check the cavity and improve the quality of deobstruction if necessary. At the end of the procedure, insert a 20 French 3-way catheter and wash thoroughly. Maintain a continuous washing until the next morning. The catheter is usually removed within 24 hours.